In this video, we will be performing a movement analysis of wheelchair propulsion. It will be done by Caitlin Brumley, Dalton Barron, Tori Evans, and Kate Martin.
Patient has an incomplete T6 spinal cord injury. The signs of a SCI are potential loss of motor or sensory function below the level of injury and pain. Symptoms are incontinence, spasticity, autonomic dysreflexia, weakness, tingling, orthostatic hypotension, and muscle atrophy. According to evidence, movement analysis knowledge of kinesiology and biomechanics are required for effective OT evaluation and intervention in relation to an SCI. Research published by Forte and Teixeira proves that understanding proper movement patterns and techniques with the objective to reduce the risk of injury leads to better health outcomes. The AOTA OT framework is a foundational document used to determine the occupational therapist's role and scope of practice, as well as identifying factors, structures, and client occupations that they participate in. Therefore, it is important for SCI patients, as well as other individuals and their conditions, because of the emphasis on client-centeredness and identifiable deficits, which helps to determine the occupational profile that directs the patient's plan of care. According to the AOTA Vision 2025, occupational therapy is accessible, collaborative, effective, and produces leaders in a variety of settings. OT is accessible through providing customized services, collaborative by excelling to work with caregivers, doctors, and other therapists. OTs are leaders through creating positive change for their clients as well as environments. For example, being a case manager for our patients and advocating for them in the public to ensure accessibility and ability to live as independent as possible, as well as ensuring proper care. OTs are effective through using evidence-based practice, client-centered approaches, and cost-effective interventions and care.
Our client Nash has a grade C incomplete spinal cord injury of his T6 from a motorcycle accident. He really values his independence and has always worked hard for what he wants. One of Nash's biggest struggles after his injury has been getting around using his wheelchair within the community without assistance from his caregiver. Many of his struggles are from the changes that have occurred to his body after his injury, such as his muscles and tendons beginning to atrophy and his impaired nervous system impacting his sensation and loss of motor function below his level of injury. Along with his loss of function and voluntary movement of his muscles in his lower extremities, he also has loss of control of his bowel and bladder. One main change that occurred is making his home more accessible while using new products and technology in his everyday life that he hadn't used before. A new personal change that has occurred from his injury is gaining a new cultural identification as a wheelchair user and paraplegic. A routine that has changed for Nash is his struggle to navigate the grocery store while in his wheelchair, and he hopes to one day be able to do it without assistance from his caregiver.
For phase 1, the movement we analyzed was static sitting in a wheelchair. As we can see in the chart, beginning at the right/left joints, the atlanto-occipital, it's just one joint, but there's right-sided muscles and left-sided muscles. The atlanto-occipital joint is in flexion in the sagittal plane and frontal axis. The main agonist muscle is the rectus capitis anterior, and the main antagonist muscle is the rectus capitis minor. Next, we're moving on to the acromioclavicular joint. So there are two acromioclavicular joints on the body, one on the right side, one on the left side. There are also right-sided muscles and left-sided muscles. This will be like this for the remainder of the analysis. The acromioclavicular joint is in retraction in the sagittal plane and frontal axis. The main agonist muscle is the trapezius, and the main antagonist muscle is the pectoralis major. Next is the sternoclavicular joint in protraction in the sagittal plane and frontal axis. The agonist main muscle is the serratus anterior, and the antagonist main muscle is the middle trapezius. Next is the scapulothoracic joint in retraction in the sagittal plane and frontal axis. The main agonist muscle is the rhomboid major, and rhomboid minor. And the main antagonist muscle is the serratus anterior. The glenohumeral joint is next in abduction. The main agonist muscle is the deltoid, and the main antagonist muscle is the latissimus dorsi. Moving on to the humeral ulnar and radiohumeral joints, they are both in flexion in the sagittal plane and frontal axis. The main agonist muscle is the biceps brachii, and the main antagonist muscle is the triceps brachii. Next is the radial ulnar joint and pronation in the transverse plane and longitudinal axis. The main antagonist muscle is the pronator teres. The antagonist muscle is the supinator. Next is the radiocarpal joint in flexion in the sagittal plane and frontal axis. The agonist muscle, the main one, is the flexor carpi radialis and flexor carpi ulnaris. And the main antagonist muscle is the extensor carpi radialis longus and brevis and extensor carpi ulnaris. Next is the first digit CMC, both right and left sides again. Inflection in the frontal plane and sagittal axis. The main antagonist muscle is the extensor pollicis longus and extensor pollicis brevis, and the main agonist muscle is the flexor pollicis longus and brevis. Next is the first MCP inflection in the frontal plane and sagittal axis. The main agonist muscle is the flexor pollicis longus, and antagonist is the extensor pollicis longus. Next is the first IP joint, an extension in the frontal plane and sagittal axis. The main agonist muscle involved is the extensor pollicis longus, and the antagonist muscle involved is the flexor pollicis longus. Next, for the upper body, we have the second through fifth digit MCP and PIP, both in flexion in the sagittal plane and frontal axis. The main agonist muscle is the flexor digitorum superficialis, and the main antagonist muscle is the extensor digitorum. And last, for the upper body, is the second through fifth digit DIP, inflection in the sagittal plane and frontal axis. The main agonist muscle is the flexor digitorum profundus, and the antagonist as the extensor digitorum. Now for the lower body, starting with the acetabulofemoral joint, again, we have one on the right and the left side, as well as the right-sided muscles and left-sided muscles. So the acetabulofemoral joint is in hip flexion in the sagittal plane in the frontal axis. The main agonist muscle is the psoas major, and the antagonist main muscle is the gluteus maximus. Next is the tibiofemoral joint in flexion in the sagittal plane and frontal axis. The main agonist muscle is the biceps femoris, and antagonist is the vastus intermedius. Next, we have the talocrural joint, which is in planar flexion in the sagittal plane and frontal axis. The gastrocnemius is the agonist muscle, and the antagonist main muscle is the tibialis anterior. And next is the subtalar and transverse tarsal joints, which is in eversion in the frontal plane and sagittal axis. The muscles involved of the agonist are the fibularis longus, and the antagonist muscles are the tibialis anterior that are mainly involved. The first MTP and IP is in neutral in the sagittal plane and frontal axis. The agonist muscle is the extensor hallucis longus, and the antagonist muscle is the flexor hallucis longus. Next is the second through fifth MTP, PIP, and DIP joints. And this is in neutral in the sagittal plane in the frontal axis. The agonist muscle is the extensor digitorum longus, and the main antagonist muscle is the flexor digitorum longus. And last is the trunk, which is the intervertebral, inner body, facet, and costal joints. These are all in extension, which is in the sagittal plane and frontal axis. The main agonist muscle involved is the longissimus, intercostalis, and the spinalis. The main antagonist muscle involved is the rectus abdominis.
For phase 2, the movement we analyzed was going from static sitting to grasping the wheels in preparation to move forward. Beginning with the atlanto-occipital joint, the neck is in flexion, and the movement is occurring in the sagittal plane along the frontal axis. The main agonist involved in this movement is the rectus capitis anterior, and the main antagonist is the rectus capitis posterior minor. Moving on to the acromioclavicular joint, the joint is in retraction. The movement is occurring in the sagittal plane and the frontal axis. The main antagonist is the trapezius. The main antagonist is the pectoralis major. For the sternoclavicular joint, it is in protraction and it is moving in the sagittal plane along the frontal axis. The main agonist is the serratus anterior. The main antagonist is the middle trapezius. For the scapulothoracic joint, it is in protraction and it is moving along the sagittal plane and the frontal axis. The main agonist is the serratus anterior and the main antagonist is the trapezius. For the glenohumeral joint, it is in extension, and we're moving in the sagittal plane and the frontal axis. The main antagonist is the latissimus dorsi, and for the main antagonist, it is the anterior deltoid. Moving on to the radiohumeral, it is in flexion, and it is moving in the sagittal plane and the frontal axis. The main agonist is the biceps brachii, and the main antagonist is the triceps brachii. For the humeral ulnar joint, it is in flexion, and it is occurring in the sagittal plane and the frontal axis. The main agonist is the biceps brachii, and the main antagonist is the triceps brachii. For the radio-ulnar joint, it is in pronation, and it is occurring in the transverse longitudinal plane. The main agonist is the pronator teres. The main antagonist is the supinator. For radiocarpal joint, it is in wrist extension and radial deviation. The main agonist is the extensor carpi radialis longus. The main antagonist is the flexor carpi ulnaris. For the first digit CMC joint, it is in flexion along the frontal plane and the sagittal axis. The main agonist is the flexor pollicis longus, and the main antagonist is the extensor pollicis longus. For the first digit MCP joint, it is in extension along the sagittal plane and the frontal axis. The main agonist is the extensor pollicis longus, and the main antagonist is the flexor pollicis longus. For the first digit IP joint, it is in extension along the frontal plane and the sagittal axis. The main agonist is the extensor pollicis longus, and the main antagonist is the flexor pollicis longus. For the second through fifth digit MCP and PIP, they are in flexion in the sagittal plane and the frontal axis. The main agonist involved is the flexor digitorum superficialis, and the main antagonist is the extensor digitorum. For the second through fifth digit DIP, they are in flexion as well in the sagittal plane and the frontal axis. The main agonist is the flexor digitorum profundus, and the main antagonist is the extensor digitorum. Due to the nature of the client's injury, the lower body is unchanged from the previous phase.
For the final phase of the movement, we will be going over the forward propulsion of the wheelchair. For the forward propulsion phase of the movement, we are going to be starting with the atlanto-occipital joint. It is going to be in flexion in the sagittal plane and frontal axis, with the rectus capitis anterior being the main agonist, and the rectus capitis posterior, major and minor, being the main antagonist. For the acromioclavicular joint, it is going to be in protraction in the sagittal plane and frontal axis, with the pectoralis major being the main agonist and the trapezius being the main antagonist. For the sternoclavicular joint, it is going to be in retraction in the sagittal plane and frontal axis, with the trapezius being the main agonist and the serratus anterior being the main antagonist. For the scapulothoracic joint, it is going to be in protraction in the sagittal plane and frontal axis, with the serratus anterior being the main agonist and the trapezius being the main antagonist. For the glenohumeral joint, it is going to be in flexion in the sagittal plane and frontal axis, with the anterior deltoid being the agonist and the posterior deltoid being the antagonist. For the humeral ulnar and radiohumeral joints, they are going to be in extension in the sagittal plane and frontal axis, with the triceps brachii being the main agonist and the biceps brachii being the main antagonist. For the radial ulnar joint, it is going to be in pronation in the transverse plane and longitudinal axis, with the pronator teres being the main agonist and the supinator being the main antagonist. For the radiocarpal joint, it is going to be in ulnar deviation in the frontal plane and sagittal axis, with the flexor carpi ulnaris being the main agonist and the extensor carpi radialis being the main antagonist. For the first digit CMC joint, it is going to be in flexion in the sagittal plane and frontal axis, with the flexor pollicis longus being the main agonist and the extensor pollicis brevis being the main antagonist. For the first MCP joint, it is going to be in flexion in the sagittal plane and frontal axis, with the flexor pollicis longus being the main agonist and the extensor pollicis longus being the main antagonist. For the first IP joint, it is going to be in flexion in the sagittal plane and frontal axis, with the flexor pollicis longus being the main agonist and the extensor pollicis longus being the main antagonist. The second through fifth MCP and PIPs are going to be in flexion in the sagittal plane and frontal axis, with the flexor digitorum superficialis being the main agonist and the extensor digitorum being the main antagonist. Then for the second through fifth DIPs, they are going to be in flexion in the sagittal plane and frontal axis, with the flexor digitorum profundus being the main agonist and the extensor digitorum being the main antagonist. As for the lower body, due to the nature of the client's injury, the lower body is going to be unchanged from the previous phases. For our evidence-based practice, we used these two questions to help facilitate our research. For the first question, it is what evidence depicts or links the relationship of movement dysfunction to occupational performance? In a study by Frederick et al., it discusses how wheelchair users struggle to participate in the community due to being unable to operate vehicles and often have to rely on external services for transportation. These services, such as taxi cabs, often do not accommodate for wheelchair users and may be unable to assist with transfers the individuals may be unable to do on their own, stopping them from being able to participate in their community. Another study by Smith et al. Discusses how pain, specifically shoulder pain, is a limiting factor in the ability of wheelchair users to participate in their community. And then for the second question, it is what evidence exists to support the need for occupational therapists to address movement dysfunction. In a study by Charlton et al., it discusses how manual wheelchair training is often facilitated by a skilled health professional, which can include occupational therapy. It also discusses how wheelchair training programs mainly focus on skill acquisition, improving confidence with the wheelchair, and using proper body mechanics during propulsion. All of these are areas in which occupational therapists can provide skilled services to help facilitate and improve individuals' wheelchair use.
The first assessment we chose for our client is the functional independence measure. This assessment will assess what level of disability the patient is at and will help us to identify the amount of assistance needed to perform his ADLs. The populations for this assessment is MS, SCI, TBI, stroke recovery, Parkinson's disease, and older adults, and the age range for this assessment is 18 to 65 plus years old. The reliability is, for the inter-rater reliability, is 0.85. The intra-rater reliability is 0.90. For the validity, the construct validity is 0.73. The second assessment we chose is the Wheelchair Skills Test Questionnaire. This assessment will assess our patient's skills at maneuvering his wheelchair. This will help us to determine how effective he is at moving within the community. The population for this assessment is spinal injuries, TBI, and stroke, and the age range for that is 25 years old to 58 years old. The reliability for this assessment for the inter-rater reliability is 0.855, and the intra-rater reliability is 0.95. For the criterion validity, it is 0.54.
And here are our references.